And welcome all to the Bipartisan Policy Center. I'm Bill Hoagland, Senior Vice President here with the Bipartisan Policy Center, and I have the pleasure of working with and alongside this fine health team. Today we're releasing a report, I hope you picked it up outside here, called The Next Steps in Chronic Care. And it was a report that was led by Catherine Hayes here and our Director of Health Policy and her team. Last November, some of you were here when Senator Chairman Orrin Hatch and Ron Wyden joined us to talk about the passage of the Bipartisan Budget Act of 2018. And that act included, as many of you know, the Chronic Care Act. And that Chronic Care Act included a provision that permitted the coverage of targeted non-medical benefits in Medicare Advantage managed care plans. At that event, I think it was raised with the senators that there was a concern that 2/3 of Medicare beneficiaries are in fee-for-service, and many who live, quite frankly, in rural areas, and who would not generally benefit from the expansion of non-medical benefits since they were not in Medicare Advantage programs. BPC took on the challenge at that time of identifying ways to expand targeted non-medical benefits to Medicare fee-for-service participants without adding to the cost of the program. As an old budgeteer, and oh, by the way, who still believes deficits matter, but I'll take that to another time, I am particularly pleased that today's report points a pathway that would extend coverage of at least one non-medical benefit in Medicare fee-for-service while not adding to the cost. Indeed, I think correctly targeted to Medicare fee-for-service enrollees with chronic illnesses, we think it is possible that we could save federal taxpayers' dollars while providing needed non-medical benefits. You will hear from Apara Higgins here shortly on the analytics behind our thinking and why we can say this. But for now, let me first thank the SCAN Foundation and the Commonwealth Fund for their support of this project, and introduce first Dr. Bruce Chernoff, President and CEO of the SCAN Foundation. I first met Dr. Chernoff in 2013, I believe it was, when he served as the chair of the Federal Commission on Long-Term Care that produced, and by the way, Bruce, I still have it here, produced this Federal Commission report on long-term. And by the way, I think there's a couple of recommendations in here that coincide very nicely with where we are today with this program. Dr. Chernoff completed his chief residency in internal medicine, as well as the fellowship in medical education at UCLA, his medical degree from UCLA, and his undergraduate degree from Harvard. So without further ado, Dr. Chernoff.
Well, good morning, everybody. It's great to see a full room here. I really appreciate seeing all of you today. On behalf of the SCAN Foundation, I want to begin by thanking our colleagues at BPC for another really thoughtful, robust body of work. We're on a journey about transforming how Medicare and Medicaid operate to better serve those with substantial needs. And this report is, I think, an important addition to our knowledge and to policy drivers that we need to pursue. I think for me, just picking up where Bill left off, the Chronic Care Act is a step. It's the first time in Medicare that we start to acknowledge that home and community-based services can play a role in improving health outcomes, and that they can work in a collaborative way with health systems to achieve those outcomes. But as Bill rightly pointed out, it's only in Medicare Advantage. It's very particular. Now that's a great thing. It's a step in the right direction. But as a physician, I would say there are other populations that are not in Medicare Advantage that we need to be talking about. We need to be thinking a lot about dual eligibles who have a unique and different set of benefits available to them. So there's an opportunity, I think, to look at all those older adults and younger adults with functional needs. There's an opportunity here to really revisit how we link services to improve outcomes. Targeting is super important. Being specific about which services we offer is really important. And so today is another step in that discussion. The Chronic Care Act is a really important piece of the puzzle. It actually opens up a set of discussions that we need to have about how do you implement these things. What does equity look like? What does sustainability look like? What does management look like? How do we actually educate and empower individuals and families to know about these services, to use these services? We want plans to be successful. We want to be able to challenge CMS and say, why are these supplemental benefits as opposed to core Medicare benefits? When should they cross over? How do we collect the data to make that case? So we're on a path, BPC, the whole team here at BPC, but with real acknowledgement to Bill and Catherine Hayes. We've been on this journey a while. There's more to do, and we just need to keep going. I'd be remiss if I didn't end by acknowledging and thanking our colleagues at the Commonwealth Fund. Melinda Abrams will speak in a moment, but we feel very fortunate to have colleagues who care as deeply about these issues as we do, who are committed to improving the lives of all those with complex needs, and we do this work together. So with that, I'm going to turn it back to Bill.
Thank you. Thank you, Bruce. And just one last introduction here, another partner, as Bruce has already mentioned, and we very grateful for their support, the Commonwealth Fund. Melinda Abrams, I understand, has just been promoted. She's a senior vice president at the fund, a prolific researcher, an author, in demand on many national committees and boards for both private and federal agencies. Melinda's degrees are from Cornell, and again, another Harvard graduate. I feel rather inadequate with all these Harvard graduates around me this morning, but Melinda, take it away.
Thanks, Bill. As Bruce said, the Commonwealth Fund is like the SCAM Foundation. We're so pleased to work together. We work actually with 4 other foundations and a 6-foundation collaborative. We have this joint mission and this joint goal to improve care and try, particularly for people, adults with complex needs, but also with an attention to helping to reduce overall healthcare costs, particularly to the Medicare program. And we know that a majority of what we call high need, high cost populations or adults with complex needs are covered by Medicare. We also know that the spending in the Medicare program is concentrated among those who have complex medical needs. In fact, about 10% account for about 60% of the Medicare spending. But we also know, which is why we've engaged in this work, that a lot of Medicare beneficiaries have social needs in addition or as a result of or in association with their medical and complex health care needs. So there's a lot of data in the report, but I just have to kind of say that when I looked at it among the Medicare population, 24% are food insecure, 25% rarely drive, and by 2050, a really large percentage of elderly without the number of elderly without stable housing is expected to double. So our journey together has shown us that there are promising interventions, and there is evidence around those interventions that can address the health, that are evidence-based, and that can address the health-related social needs, so affecting their health care, their health outcomes, by addressing some of the social needs. And there is evidence about these interventions, some of which we'll talk about today, and one of which is particularly detailed in the report. And we were proud, and have been proud, and privileged to work with the BPC as part of this ongoing series. Bruce and Bill both mentioned a previous report, one of which we were lucky enough to co-fund, to figure out what the next steps are that we should take. And we know that value-based payment is essential. is it really essential to actually achieving this integrated care that meets the whole person needs of these Medicare beneficiaries. So what today's report outlines for all of us is additional options to address those needs, particularly for those with chronically ill. And it focuses on the dual eligibles. There's a set of recommendations in traditional Medicare, particularly ACOs and comprehensive primary care models. And then also, in addition to the legislative achievement of the Chronic Care Act from 2018, some recommendations about how we can build on that and make sure that we really deliver on the promise that is part of that legislation, much of which was built on previous work and analysis done by the Bipartisan Policy Center. Of course, there are challenges when addressing the health-related social needs of this population. Bruce mentioned some, a lot of challenges regarding implementation, workforce, quality measures, capacity, but without the policy agenda and the financial incentives in Medicare, we're not going to be able to move the needle. We're not going to be able to improve care for people and their families. And that's what we get in today's report, much needed practical guidance, tangible, actionable recommendations to help us improve care. So we're really excited about the report. We're excited about the partnership. And of course, none of this would have been possible without Catherine's leadership and her entire team, including Bill and many others. And special thanks also to Aparna Higgins and the analysis, the analytic work taken on by Ananya Health. So with that, thank you all very much for being here, and I look forward to the discussion.
Hi, I'm Catherine Hayes, Director of Health Policy here, and we're releasing a report today that really has three separate parts. One, as Melinda mentioned, that's bad when you get your funder's name wrong, I just want to say. As Melinda mentioned, that deals with recommendations to help further integrate care for duals, and we're lucky to have Tim Engelhardt with us here today, who has done so much work in that area, and appreciate his assistance with that. The second would look a little bit more with go a little bit further with special supplemental benefits for the chronically ill and Medicare Advantage. But I think the most forward-leaning approach in this is a pathway to offer non-medical benefits in Medicare fee-for-service. And I want to be clear to begin with that every single leader here at BPC is very much committed to moving to a value-based system. But it's going to be slow going. Right now, we've just convened a rural health task force that is being led by Marilyn Serafini and Anand Parak. And there we will be looking at alternative payment models that will work in rural areas. But for now, we are hoping to expand the availability of non-medical services in Medicare fee-for-service. And certainly, having working for Bill Hoagland, we know that the budget is a huge issue. And so we've carefully designed this benefit to assure that it will not add significantly to Medicare costs, not only because of the deficit, but because adding benefits will increase Medicare Part B expenses and increase beneficiary premiums, as well as increase out-of-pocket costs for Medicare beneficiaries under Part B. So what we structured here was an approach that would give the Secretary, and this would require legislation, it would give the Secretary the authority to expand non-medical benefits in Medicare fee-for-service only if certain conditions are met. And those conditions include strong evidence to show that the proposed benefits are cost-effective. They have to be certified by the Medicare actuary that they do not add to net costs in the Medicare program over the long term. And these benefits, clearly you need some sort of gatekeeper to make a determination as to whether or not an individual is eligible for these benefits. So we would envision that these benefits would be available to Medicare beneficiaries who are either receiving services through an accountable care organization or some other alternative payment model, or are under the supervision of a physician and receiving chronic care services. So with that, we are really hopeful that this will move forward. I would like to introduce Aparna Higgins, who is the founder of Ananya Health Solutions and a senior fellow with the Duke Margolis Center.
Thanks, Catherine, and good morning, everybody. So I'm going to give you a high-level overview of the analysis that we did to support the recommendations that were in the BPC report. So as Catherine mentioned, so one of the recommendations in the report relates to provision of supplemental benefits for certain eligible cohorts of Medicare beneficiaries. And what we wanted to do with this analysis is illustrate the characteristics of patients who could potentially be eligible for these kinds of benefits. And then also for those cohort of patients, kind of illustrate costs and benefits associated with providing certain specific types of benefits, like medically tailored meals, which we'll talk about in just a second. So again, to Catherine's point, this is not, benefits for all of Medicare fee-for-service, but for patients who are eligible and who we think would benefit from these kinds of particular benefits. Our analysis was based on the 2016 Medicare Current Beneficiary Survey. So we used that data that includes both data reported by the beneficiaries, but also has information on utilization patterns in the data. And our starting point was the recommendation by BPC that the patients who could benefit from these services would either have, 2 or more chronic conditions, and plus have some deficit in terms of activities of daily living. So we thought that this was a cohort. But then the question becomes, okay, what are those chronic conditions that people have that would, lend itself to improvement through making these kinds of services available? So we selected a set of 11 conditions, and we thought that these would be ones where provision of supplemental benefits could help in avoiding adverse utilization as well as costs. A full list is available in the report, but some of the conditions that are included are depression, congestive heart failure, diabetes, Alzheimer's or dementia. So things that if you looked at it, you would say, oh yeah, it makes sense, right? And then we also so that was our baseline cohort, and then what we did was we filtered further. We wanted to look at subsets of that cohort that had either inpatient utilization stays or had things like trouble with transportation for medical purposes in terms of getting to office visits or other kinds of consultations with clinicians, and also those who live alone, because they're more likely to be vulnerable. And to illustrate the potential budgetary impacts of a hypothetical benefit, we actually selected the provision of medically tailored meals for Medicare beneficiaries who were discharged from after an inpatient stay, but the provision of the benefit was time limited. It was, for a 7-day period post-discharge, because there's evidence to show that that kind of tailored benefit actually helps reduce readmissions, ED visits, and potentially, skilled nursing facility stays. So that was sort of the defined benefit, as Catherine was referring to earlier. And so based on that defined benefit, and then we looked at a cohort of individuals that had, at least 2 or more of the 11 conditions that were listed in the report, had at least one deficit with the activities of daily living, had some kind of food insecurity, as well as had been admitted to the hospital and had at least one inpatient stay during that 2016 period. So based on those criteria, we actually looked at that cohort, and there are estimates that show that about 17% of an inpatient stay actually results in a readmission, so we use that estimate. And then there's the evidence from the literature also shows that about 13% of those readmissions could potentially be averted through the provision of a medically tailored, meals to those patients. So kind of putting together the MCBS data, as well as some of the evidence from the literature, and sort of developing national estimates, we found that there would be approximately 575,000 Medicare beneficiaries who would benefit from receiving medically tailored meals post-discharge, and that these were associated with over a million inpatient stays. And based on the readmissions averted, our focus was on readmissions. Part of this is data limitation. MCBS doesn't have data on ED visits, so our focus was on readmissions. We could avert readmissions in this population, and that would result in a net savings of approximately $57 million. So essentially what it boils down to is for every dollar you spend in the program, you have a savings of $1.57. I will end by saying that our analysis is a starting point, and then we believe that for this to become part of the Medicare program, we need further refinements, both in terms of cost and benefit projections, but also thinking about this in terms of how do you refine targeting, how do you really identify these people in the real world, which goes to the functional assessment piece that's also part of the report. And then also to Catherine's point that all of this needs to be thought of being delivered in the context of a care delivery system. This is not you just give them meals and say, okay, see you tomorrow or a week later, right? So this is very much in the context of changing care delivery as well. Thank you.
Thank you, Aparna. I'd like to at this time ask the panel to come forward. Our moderator today is our Health Project Director, Marilyn Serafini, who is a great asset to BPC. Thank you.
Great. Thank you very much, Catherine. And I don't want to go over all the ground that you've already heard covered for our report. As we're going through our conversation, we're going to get more into the details of some of our recommendations. But for right now, what I'd like to do is introduce our panelists and to turn to them for better analysis to give us some perspective about where we are and why we're doing this. So to my left, we have Sean Martin. He's Senior Vice President of Advocacy and Practice Advancement and Policy for the American Academy of Family Physicians. Ann Tumlinson, who's CEO of Ann Tumlinson and Innovations, and has been doing quite a bit of work in this area. She's going to tell you about that. Chuck Milligan, who is National Dual Eligible Special Needs Plans Executive Director at United Healthcare. And at the end, Tim Engelhardt, who's Director of Federal Coordinated Healthcare Office at the Centers for Medicare and Medicaid. Okay, so Sean, let's start with you. Can you talk to us about the role of family physicians in chronic care? How much care management is already going on, paid or unpaid? And how do family physicians, how do primary care providers identify people in the real world who could benefit from some of these benefits?
Right. Well, thank you. So first of all, congratulations on the report. I had an opportunity to read through it. Incredible alignment, I think, with how the Academy sees opportunities in the system. So right now, about 60% of care for the top 10 chronic conditions are provided by primary care. There's a belief that specialization is driving a lot of the care of individuals with chronic conditions, and that actually is not what is happening across healthcare, across communities in the country. So I brought our latest statistics. So about the first thing that I think is happening is about 42% of our members are using some type of risk stratification tool in their practice. So they're going through a process to identify individuals and grouping them based upon disease or high cost, high need in their practice. That's a pretty significant number of physicians that are doing that. The problem with that number is the smaller the practice, the less likely they're to do that. So solo physicians are less likely than a group of 10. About 44% of our practices are engaged in some type of care management activities within the practice, paid or unpaid, they are doing it. About 54% of our practices are engaged in some type of care coordination across the healthcare community where they practice. There's a large level of coordination that's taking place. We also asked a question about the amount of time devoted to non-face-to-face, clinically related activities, and it averages about 3 hours per physician per week. So there's a lot of activity. There's an acknowledgement and an engagement in activities that are related to the betterment of health that are not taking place with the patient directly in the exam room. So those are all encouraging numbers. They're not necessarily good numbers, but I think there's a solid foundation in place amongst family physicians.
Okay, great. So, Anne, why are we having this conversation in the first place? And why is it hard at looking to offer these kinds of benefits in fee-for-service? And tell us about your work.
Sure. So, so I just want to say, like, I'm having a little bit of like a cognitive dissonance right now because, 20 years ago when I worked at the Office of Management Budget, the idea that Medicare would in any way, shape, or form ever contemplate in any universe the coverage of benefits, not programs or interventions, but actual benefits that are not medical it was like an unheard of thing. And, but I guess over time, so first of all, if you think about all the people who are Medicare beneficiaries today, over age 65. We tend to have a lot of these conversations around dual eligibles, which is really important. But 2/3 of those who have multiple activity of daily living limitations are actually not dually eligible. And actually, half of those are low income, so they're probably going to become dually eligible at some point, but they're not there yet, and they do have very complex care needs that include functional impairment and chronic conditions. So I think there's been this advancement in the conversation as we've kind of entered into the world of value-based care that we can't really well manage the healthcare of this population if we're not also addressing their individual needs for some of the social supports and services that they need. But the problem or the challenge is that and putting on my budget hat for a moment, is that if you say, great, we're going to cover meals, all meals are covered, and here's some criteria, that the Medicare program is going to put in place to determine who qualifies for meals, but like home health. You can get home health, but you have to have a skilled need. Well, pretty soon you have a lot of people accessing a benefit for whom that benefit may not actually really meet their individual needs, and then it ends up costing a lot of money. So we're now at a place where the science allows us to figure out what the individual needs are, who's going to benefit from particular types of interventions, and then under value-based care and under managed care, we can now put the kind of care management integration in place that allows us to actually deliver those. So this person needs an air conditioner, they're going to the hospital for heat stroke. This person's going to the hospital because they're eating spoiled food. This person's going to the hospital because, and actually, in one of the case studies we did, and this was actually in the context of dual eligibles, they were going to the hospital because nobody was cleaning out the bird cage, and so they were getting contamination. So we're talking really very specific needs in individuals' lives that if they can be met through a set of benefits that are more flexible with integration and care management, then we can have, that's when we can have not only an impact on their health outcomes, but also reduce health care. So in light of that, we convened, together with LTQA, the Long-Term Quality Alliance, we convened a working group of a very diverse array of people, including the American Health Insurance Plans, Better Medicare Alliance, the SNP Alliance, AARP, National Council on Aging. I've seen a bunch of you in the audience. And we recognize this is a big turning point. Even just in the context of Medicare Advantage, special supplemental benefits are a small part of it, but it still signals a really important turning point. So we need new principles. If we're going to address individual needs through flexibility as sort of the core principle of these benefits, we also need to have them be manageable They have to be sustainable. They have to be clear to the consumer. They have to evolve over time. So we are also releasing today, in conjunction with this work, the guiding principles and we actually got all of these organizations to sign on as a consensus document, which is a miracle. So, so we're really excited about that and the possibility for this new degree of flexibility in the Medicare program.
Fantastic. So Chuck, I'm going to turn to you now. You are our sole health plan person here on the panel. What we do know about the law that Congress passed last year is that health plans can start offering some benefits already in 2020. Talk to us about the process that United has been going through in thinking about what kinds of benefits to offer. I don't know how much you can tell us about what United might be offering in 2020, but even the thought process and what the factors are that an organization like United has been thinking about.
Sure. Now I regret that I don't have a report to release today. Great work, everybody. It's a privilege to be here. So when we look at benefits, and I'm having a little bit of a cognitive dissonance moment too. I've been a Medicaid director in a couple of different states, and it's so kind of welcome to see where Medicare is going in general with all of this. When we look at benefit design and benefit bids and filings, we look at kind of three broad categories. One is what do potential members pursue, and what are they interested in? And that would typically be things like over-the-counter drug benefits, dental benefit, dentures and those sorts of things, vision benefits, so eyeglasses, eye exams. So kind of working around what the Medicare benefit structure is. So the first big category is what do members pursue. Second big category for D-SNPs in particular is what do our steps.
Define a D-SNP?
Yep, I'll define it. Thank you.
So, and actually, let me say that, clarify that what can be offered next year is in the Medicare Advantage program,
right,
which is 1/3 of Medicare beneficiaries. And so that's something that we've addressed, but a lot of what we're talking about in this report is how can we make that available in fee-for-service. So I just wanted to clarify that before you continue.
Yeah, thank you. I was going to pivot there myself, but I appreciate the reminder about the acronym. So dual eligible special needs plan. And so when we look at this, so the second broad category is what do our state Medicaid agency partners hope we do in terms of the relationship and the linkage to Medicaid. So that would be often things like sort of buying down the cost sharing, so it reduces the Medicaid costs for the deductibles and coinsurance types of things. And sometimes Medicaid agencies want us to kind of wrap around Medicaid, so how can we kind of build around the limitations of the Medicaid program or the limited availability of some of those benefits to certain dual eligibles. But the third broad category is what advances health and health outcomes. And in that area, it's incredibly welcome where the new supplemental benefits are going. We look at things like transportation as a benefit to help get individuals into care, to close their gaps in care, to have access to care. We look at things like environmental modifications to help avoid falls and those sorts of things. But we are very attentive to a lot of the new flexibility here around, the meals is a great example. A successful readmission avoidance strategy is to make sure that when somebody's discharged, they have what they need when they go home. And that's often nutrition. And it's not simply to kind of treat their disease state, which is obviously critically important, but it's also when they go home from the hospital, they may not get to the grocery store right away. And how do we help deliver the meals they need at home? So those are kind of the broad ways we look at it. And in Medicare Advantage, broadly, it's very much the same kinds of considerations, but for the Medicaid agency sort of piece of this. How can we drive health outcomes? How can we improve stars? How can we, advance population health broadly? And I can't get into a lot of details around what's in the 2020 bids as we kind of get ready for open enrollment. But it's incredibly welcome where the new benefits and the new approach to benefits is going.
Okay, thank you. And so last but not least, Tim, can you give us an update on the financial alignment demonstration and lessons learned to date?
Again, I want to pick up on the cognitive dissonance theme because I don't want to be dramatic, but I do think the stuff we're talking about today is reflective of the fact that we're in this kind of dynamic phase of the punctuated equilibrium of the Medicare program at age 55 now, or whatever it is. That transition that has been happening at different points in time, the early 2000s with Part D, and I think again of movement from a kind of commercial market-based acute care program into a program that's more reflective of the population it serves right now, which are people with multiple chronic conditions with longer life expectancies who are more likely to die from a chronic illness than some infectious disease. And I think it's work of a lot of people, but the Bipartisan Policy Center and SCAN and Commonwealth who have really kind of driven that movement, and so I'm really appreciative for all of the work that they have done to help bring us to this point. I come from CMS, and a small part of CMS that represents the 12 million people who are dually eligible for Medicare and Medicaid, and it bears reflection that that's a really diverse population. It's low-income older adults who are in nursing facilities, who are in the community. It is 40% of that population are people under the age of 65, many of them with serious and persistent mental illness, others with physical disabilities or developmental disabilities. So it's this broad array. What unites at least a lot of that population is a high prevalence of chronic conditions and social risk factors that make the topic of discussion here really, really germane to the population. One of the big strategic priorities at CMS in this current year is improving care for that population, dually eligible beneficiaries, and we've been addressing it through two main strategies, right? The first is modernizing the Medicare savings programs, and the MSPs don't get talked about a lot, but these are the Medicaid programs that actually help low-income people afford their Medicare coverage, right? The premiums and deductibles and cost sharing that otherwise literally put Medicare coverage out of reach. And so modernizing those programs really means fulfilling their promise and ensuring that data exchange between government agencies is timely and accurate, and that the eligibility process for beneficiaries is efficient and timely, and that no one is illegally and inappropriately billed for cost sharing that by statute they shouldn't ever have to pay. And so that's a big point of focus for us. The other is promoting integrated care. And in dual eligible world, we think of integrated care as trying to make a beneficiary's experience in two different health insurance programs as seamless as possible between them, and trying to mitigate or eliminate the perverse cost-shifting incentives between the two programs, right? And so integrated care has many different forms. Programs of all-inclusive care for the elderly, and in kind of the marriage of dual-eligible special needs plans with Medicaid, managed care programs. And we're also testing what I think are innovative new delivery system reform, integrated care models with 11 different states right now. And slowly, quietly, we've built we and our external evaluators have built an evidence base about those ongoing model tests right now. And the results are, I think, really important. And so starting with the fact that consumer satisfaction in these various integrated care products is really high, and that's really important to us for a lot of different reasons. But secondly, on the cold analytics, relative to a matched comparison group, I'll just give you some highlights of our early findings. The probability of long-stay nursing facility placement has declined by 12% in Massachusetts and by 24% in Washington State. Inpatient admissions down by 15% in Illinois, 21% in Ohio. Similar trends in post-acute Medicare SNF benefits. And in multiple states, statistically significant Medicare savings at the same time. So there's much more for us to learn and to evaluate and to improve, but it gives even the jaded among us some level of optimism that, like, yes, we can improve outcomes for beneficiaries and save money at the same time. But the numbers are they're really important, but our ability to effectively measure what really matters to the population we serve is still imperfect, to say the least. And so it's the genuine, like, beneficiary stories still really matter for this population and for the work that we do. And I collect them with great regularity in my capacity at CMS. It is very rare that we get stories about the poor delivery of medical care within the four walls of a clinic or hospital. Like, those things happen, right? But those aren't the driving concerns and successes and challenges that we primarily hear about. What they are reinforcement that the rest of my life matters more than the very small fraction of my life in which I'm in some healthcare setting, right? So what that means is that this non-medical stuff really matters. And we frequently hear challenges from beneficiaries that really amount to, like, a complete disconnection from any meaningful treatment protocol. So people with serious mental illness are getting no treatment whatsoever. People who haven't seen a doctor in years, despite the fact that they don't have one form of insurance, they have two, right? And so it's the successes for the population we serve start with connecting people to services that they're eligible for and have been eligible for, but from which they have been completely disconnected. And it's the challenges of low literacy, of housing instability, of transportation barriers, of trauma, sometimes from the medical system. Each of those are the reasons why people have become disconnected from the services that they need to maintain their independence and health in the community. And so the lessons learned are at least a little bit on the cold analytics that we can do better, both for the trust fund and for the state Medicaid agencies and for the population we serve, but that it often starts with interventions that feel very unmedical in their orientation.
So let's talk about evidence. What we do know works, what we know and what we don't know, what works, what might save money. And the BPC has made some recommendations regarding the collection of evidence. For example, requiring requiring Medicare Advantage plans to quantify and report outcomes to CMS on these benefits that they offer, and for CMS to compile this evidence for the plans and publish the reports and outcomes. So what is the significance or importance of building this evidence? Again, what do we know? What don't we know? And I'll leave that to whoever would like to start.
I'm going to start. So I want to answer your question, but I just want to say one thing that Tim made me think of about, we talk about this as a turning point and the importance of these very, very often very personal situations and challenges that people face, and the need to address those to really improve their experience of the healthcare system, but also their lives. That I think that we're also at a little bit of a turning point in the way in which insurance companies and providers interact with each other. Because I think that we can't, this sort of paradigm that the insurance company is this transactional entity that pays bills, and the providers are delivering care, and their adversaries has to be broken down and has to be reworked, because at the end of the day, the providers need to sort of be supported in the degree of flexibility that they have in order to find out and address individual needs, and the insurers have to have the confidence that that's being done in a way that's going to help them achieve the health outcomes that they're accountable for to CMS. And I think we could be doing a lot more, to foster that dialogue between those two entities. This does lead to the evidence question that you ask, which is that, I think there's some work that's been done that's been very helpful, particularly in the context of meals and home delivered meals, and particularly medically oriented meals, and transportation. in my view, when I see health plans starting to pay for transportation, I figure it must be cost effective or they wouldn't be paying for it. And I think it's one of the things our working group identified is absolutely very much connected with this recommendation, the BPC report, that we have to come up with a way, and not to put another burden on health insurance companies, but we do have to have a way to be collecting the kind of experience that they are having and delivering these new benefits in a way in which we can assess, is this working, and how does that inform fee for service and the things that we do in that space. I mean, just the last thing I would say is this may be very controversial what I'm about to say, but it kind of feeds on what I said before, which is that I think anything is cost effective. I mean, anything can be cost effective if it is targeted to the right person at the right time. And I think where we have to improve our science and our evidence is really around how do we figure out who the 5 people are in this population for whom a home delivered meal will in fact improve their health outcomes and reduce their use of the hospitalization. And that's, because it could be, CMS said pest control. It could be pest control. It could be an air conditioner. It could be a home delivered meal. We can't just throw all of those out there and look for evidence, because it will look like they're failing, and they're not, right? We have to figure out it's the targeting and then the measurement that are really critical.
So panel, how do we figure out, I mean, we've got the primary care represented, the health plans, and from CMS perspective, how do we figure out who the right people are to target this to? How easy or hard is that to do?
Check.
Go fire away, Sean.
Very. Would be hard. I think it's
hard.
very hard. I think when we look at our statistics of just practices that are doing risk stratification, so they are on the leading edge of trying to identify high need individuals in their panel. So now we have to get to the step of, well, now we've figured out who they are, what are we going to do? And I think it's important to remember that further you move from like an urban epicenter, the fewer and fewer resources these practices have available to them. That's not an excuse. It's just, and time is one of those resources. They only have so much time to take care of their community. They're taking on a role of like a concierge service. I completely agree with your comment. I think the relationship between particularly primary care and health plans is far better than I personally speak about it in the media. So I think, we shouldn't lose sight of the partnership that is emerging between particularly primary care and health plans, and the kind of identification that we're in this together, and it's kind of a mutually beneficial or mutually destructive partnership moving forward. I think the other thing, the one red flag I would raise is we tend to create auditing systems with new services. And I think when we talk to our members, they would love to engage in this kind of, services beyond healthcare that contribute to health. But they worry that when they move into that territory, it comes with a pretty significant level of an auditing function or an accounting function. So the documentation and things that complicate the delivery of services that are probably really beneficial to an individual, instead of just letting them do that on a community or practice by practice or community basis. We create a system to make sure they're not abusing it. And then by creating a system that prevents fraud and abuse of that, we basically chill it out of existence, in the real world.
And as you talked about getting further and further from the epicenter, so as we get into rural areas, how much harder and why?
Well, I think in some respects it's easier if in some respects it's easier because they know everybody in town, they know everybody in the county, they're probably more capable of picking up the phone and creating the connection of services. I think where it becomes difficult is the delivery of those services are limited by proximity and geography. There's not as many people delivering them. So if you want to have air conditioners installed in all of these homes, it's going to take a long time to do that across a community, and delivering meals and other types of things are really hindered by geography. And I think we have to start thinking about technology interventions et cetera. And I grew up in a rural Oklahoma, so I know this well, but it is hard for older people that may or may not have a reliable caregiver to quote unquote go to town. And I think we lose sight of that, especially if you live in a city long enough, you forget that there's buses and metro, et cetera.
Can I comment back to a couple of these questions, or were you going to Tim, Marilyn?
No, go
So
ahead.
just jump right in.
Go ahead.
Thanks, Tim. Our small agency to my left. And I thought health plans and physicians were getting along well, but then they said "and" between us, so who knows? There are a few comments I wanted to make about evaluation and the rural issue, and I'll be really quick about this. In terms of evaluation, I think it's absolutely essential, and not just to address fiscal concerns, and I really appreciated Ann's early comments about kind of the risk that a benefit's going to be offered too broadly and to people who don't need it, won't benefit, and it's not just going to look like the benefit didn't work, but it's going to look like it's a fiscal problem. So I think the targeting, in terms of how health risk assessments are done, plans of care are developed, and there is a requirement to link the benefit to the need identified in the plan of care. There's a requirement to do all of it. I think that that's essential. United did not approach the new supplemental benefits with a view on sales or marketing. We viewed it as an approach to health outcomes, and I think I applaud BPC for its comments around, targeting this for health outcome purposes, not for sales purposes. And I think that that's an important element of this. But the other kind of factor I want to mention about evaluation is that that's the path to permanence for any program. And we've seen it with PACE, we've seen it with dual eligible special needs plans themselves, we've seen it to an extent with Medicaid home and community-based waivers, which is paying for non-medical stuff to avoid medical stuff. And the path to permanence is having good evaluation criteria that target benefits to members in need, because then it does become cost effective. The one comment I wanted to make about the rural issue, I think, and I'm going to sort of pivot to the Medicare fee-for-service work and fee-for-service elements of the BPC report. It's very difficult for a Medicare Advantage plan to file a product in a lot of rural counties because the geo-access standards are almost impossible to meet because of the degree of specialists and subspecialists you have to demonstrate in your network, which does not apply to Medicare fee-for-service. Medicare fee-for-service takes what they have. So I have, in many areas of the country, tried to build a network, and we contract with every provider in the county, but it doesn't meet geo-access, which means the Medicare fee-for-service elements of the report and recommendations, I think, are essential, partly because I think the MA geo-access standards are so biased for fee-for-service and how they're parts of the bid process. So I wanted to mention those elements too.
Great, thank you. The BPC has a rural health task force, and we're addressing some of these issues, so hopefully we'll be able to help in that area. Tim.
On the evidence question, certainly I agree with Chuck and others that the more robust body of evidence that we have that a particular thing or benefit works, however you define that, the more it helps in Congress, the more it helps with OMB. All those things are really important. Ann brought up the point that I was going to start with on research, which is when we look at the research on high-cost individuals, it's a hodgepodge of stuff that kind of works and stuff that doesn't. I think one through line in it is that appropriate targeting to the right people, the highest risk people, is a key element of success, of cost effectiveness primarily. But this collides with our notions of person-centeredness in really important ways. Just oftentimes we're trying to apply these kind of rigid rules to define a population, to test a thing, and then we see if it works or not, and then we can apply it for that population maybe in the future. What I think our lived experience helps to highlight is that people don't fit into those boxes always as neatly, and the intervention that works for one person isn't the same one that works for somebody else, even though they kind of clinically might look a lot like one another. And so, without dismissing the importance of meaningful research and evidence, I think the innovation over the last several years has been the marriage of flexibility with accountability, right? If a health plan is at financial risk for total cost of care, like, let's give them a little more flexibility in terms of what benefits they offer. And if an ACO or some other practice has a total cost of care responsibility, let's like relax a little bit about what services they can bill for or not. And so I think in some ways that gets us around the trap of trying to put everything into like randomized control trial style evidence, and it's really important. But Sean, the flip side of that is that our regulatory apparatus at CMS has to adapt. And so Chuck said, we're using this new flexibility to improve outcomes, not for like marketing advantage. But like, we got to be really careful about making sure that people don't fill their marketing materials with like, we'll pay your rent, if in fact they're not like gonna, right? And we have to make sure that a community physician isn't just like billing and rebilling for some service that the beneficiary like never really knows if they ever did, because it was a care coordination outside of the line of sight for that particular individual. So we've moved like significant steps forward, but our regulatory apparatus has to adapt, and I think some of that comes through in all of the reports that came out today.
Yeah, so I want to get back to the marketing point, but before we do that, I asked Chuck this question. I'd like to ask the other three the same question. What do you think we could potentially see for Medicare Advantage plans offering some of these benefits in 2020? What are you thinking? What are you hearing? It's tough because we just said that we still need to build the evidence. So based on where we are and what evidence or thinking we do have, what could we potentially realistically see in 2020?
That's a good question.
That's so soon.
Yeah. So maybe I would just,
Or 2021.
No, I don't have an answer, but I have to make 2 points. One is, I think it's going to be, 2019. It's really important to remember that in 2019, plans were responding to regulatory guidance only, and that regulatory guidance was pretty. It was, as it should have been, pretty narrow and pretty strict, and that the regulatory guidance in 2020, which is based on statutory change, that is a lot more flexible in the degree to which it allows plans to really think about addressing social determinants of health, and a kind of a much wider variety of things. And so, I'm optimistic. I think that plans are, with that degree of flexibility, are going to be a lot more inventive and creative than maybe they were able to be before, but that it is really just the beginning. 2020 will be just the beginning. And the second point I want to make is that I feel like it is essential. I think one of the most challenging things that I found in 2019 as just somebody who's trying to research and shed light on this issue and help providers and community-based organizations understand how they can interplay with all of this, is that we don't have a lot of good information about what is being offered. It's not an easy thing to do. There's a plan benefit file, a PBP file. It's very limited in terms of what it can tell you, because it wasn't designed for that purpose, but we're using it for that purpose. And then, if you want to know beyond that, you're kind of literally like digging through website, information on a plan by plan basis to try to figure out what's being offered. And it's frustrating, and it's not the plan's fault. It's not really CMS's fault, but I think that if we're really going to do this and go forward, we've got to figure out a way to have more visibility just in terms of what the plan offerings are. And so I just put that out there because that's what I'm going to be working on for the next 12 months.
So moving up a few thousand feet, I think we'll see plans act in my opinion, in two big buckets. One will just be beneficiary engagement. How can they create a greater amount of touch points with the beneficiary, whether that be telemedicine, the kind of ride sharing, making sure that they're connecting with their covered lives and helping them, create some type of stickiness to the healthcare system and services that may be available. I think the other one, and I think there's been a lot of work already done on this is alignment of community resources. Like Ann said, I can see, plans really being an agitator in a community of creating compendiums or rosters of just community services that already exist, making that available to, physicians, other providers, caregivers, the beneficiaries themselves. But, where can I get, fruits and vegetables? Just pick your services. But I think just trying to navigate that, if you're not, necessarily good at Google, can be complicated for a lot of people. And I can see the plans really, becoming a human search engine type of service.
Yeah. Okay. So, are we going to say something? No. Okay. Okay. So let's turn to marketing, because this is a question that's come up, and it's great to hear that United is so committed to the outcomes. There have been some concerns raised that Medicare beneficiaries could be confused if they see plans talking about these benefits. They may think, oh, I'd like to join that plan because it's going to offer me transportation or something having to do with my housing. And then, because we know that these benefits will be targeted to very specific beneficiaries with certain needs within that population, that they won't have access to that benefit. So there has been some concern raised that there could be some confusion. The BPC has recommended directing the HHS secretary to establish standard language for marketing materials to clarify that the benefit is not guaranteed, and also requiring the Medicare Advantage plans to develop materials for providers that make them aware of these benefits, the conditions under which the services are covered, and where to direct patients. So what exactly, did I get the concern right? And what should the guardrails be? Anyone?
Well, I always talk first, so I'm just waiting.
So I think it's a fair recommendation on the report. I think it's a legitimate concern, especially in a non-print advertising world where you have so much digital advertising. Geographic boundaries don't really exist in our modern advertising promotion world. I think I would just encourage transparency. I think it's important to just make beneficiaries aware, which probably means caregivers and their physicians and providers aware as well of just what the limitations are on these benefits. And I don't think, the plans or Chuck or anybody really wants these to become confrontational at the point of care. But a lot of times it's the physician that has to say, you're not eligible for this, or this isn't, available in our particular community. And, those can be difficult conversations.
Anybody else?
I do, as I said a minute ago, I think it is important. I've heard, folks say that it's not that different than other Medicare benefits already. Not everybody needs DME. But I do think that as we kind of get into this area, and I think Ann's example of home health earlier is a good example. It became a big payment integrity problem for Medicare, and I think we need to be mindful of that history. And I'm mindful of Tim's comment earlier, which, if there's going to be kind of a marketing review element of all of this and trying to make sure it's not oversold, that requires the apparatus to kind of do the administrative side of what that entails. We have seen some of what our competitors are going to be doing in 2020. There's one comment I want to make, which is I think the infrastructure to deliver a lot of the new benefits shouldn't be underestimated. And so as more of what all of the insurance plans do, all of the players in the Medicare Advantage space do, I wouldn't assume that if everybody is a little bit slower to market in 2020, I wouldn't assume that that's a lack of interest. I would just want to convey that, building the infrastructure around plans of care and tightening that, and who's going to deliver that, and how are you going to build that network of these non-medical vendors and providers is not to be underestimated.
I totally agree with that.
The regulatory and compliance angles on marketing and beneficiary communication are really important. But I'll take the flip side perspective, which is that our ability to connect whatever benefits, I mean, existing benefits, to people who need them in the community probably doesn't rest on how well we structure the PBPs or what's in a plan finder, right? Because as important as those things are to a robust and competitive market, a lot of people who are not participating as shoppers in a market, they are disconnected from a system. And so for any new benefits to have their maximum value, as much as we need to focus on regulating the potential inappropriate communication flow, we need to also focus on getting to those people who benefit the most. And a lot of that takes like heroic effort on the part of care coordinators in the community to go find the person who has been couch surfing for the last 6 months and connect them to services. But there's a role for us in state and federal government too. I mean, very simple things like the accuracy of our contact information for Medicare beneficiaries has been, ever since you've been able to get your Social Security check direct deposited, you don't have the same incentive to tell SSA when you've moved, right? So the address information we give to a health plan or to a practice is wrong a lot of time, and to find people takes a lot of interventions at the practice level, at the ACO level, at the health plan level, but at the governmental level too. And so communication has a flip side that we need to also invest in.
Can I just say one more quick thing on this topic? I mean, I think one of the things that I've just had the opportunity to observe is that, particularly in the community-based organization in the home care space, is that they are interacting with these folks because they're if you're a home care agency, somebody's contacting you and saying, and this is happening now, and they're saying, hey, my, this is actually in Florida, my United plan covers this. How can I get it? And then the agency is like, who's never dealt with Medicare before in their lives, is like, that's a good question. And so I think just building those, just to Chuck's point, building those communication channels and the infrastructure that supports the process through which the provider and the beneficiary and the plan can all connect up, even when they are aware, it's going to be really hard.
Yeah. Okay, let's open it up for your questions. Yes.
I'm Dr. Caroline Poplin. I'm a primary care physician. I'm also a Medicare beneficiary, plain old Medicare. For two things that haven't been mentioned much. The first is community services. The health, like social work. The social worker should know where all these benefits are, and plans that are reaching out to community services ought to be contributing money to those services. That's the only way they can survive. You can't expect local taxpayers to provide all these services for you. The second thing that you haven't mentioned is that complicated patients require physicians. Nurse practitioners can handle individual problems, but for somebody with congestive heart failure and some kidney damage and some history of stroke, so they're not quite cognitively intact, you need a doctor to manage the conditions, and you need continuity of care. Continuity of care is much more important than a team, and for a doctor to take care of a complicated patient, you have to pay them more because it takes a lot more time. You can't handle 2,000 patients.
So let's talk about payment and reimbursement. So, Sean, I mean, a lot of things that we have heard today have been about what you get paid for, what you don't get paid for, and we know that providers of all sorts are doing a lot of stuff that they're not getting paid for.
That's right.
So.
Well, I might offer you a job. That was very well done. So I think somebody said earlier, I think we have to reimagine payment. And Tim made this comment, flexibility with accountability, and you'll see that in some Academy letters coming back to you very soon. So I think we're thinking about payment appropriately in 2019 and moving forward. I mean, we're starting to think about the valuation of services under fee-for-service and how do we roll those up into more global capitated payment models that start to allow flexibility at the point of care to provide the services that the individual patient or the population needs. I think the limiting factor, and I don't mean to harp on this, but the auditing function of how Medicare exists with physicians is problematic. I mean, they want information reported to them about what the physicians are doing, and that is, almost the antithesis to flexibility of just saying, here's a population-based payment, go take good care of your beneficiaries. And I think it limits team-based care. I think you can't have a true team-based environment when you're constantly trying to account for who's doing what. And I'm going to close on a positive note. I think we're really, really close to being smarter about payment models that really drive this type of care, particularly at primary care. We're not there, but we are close. I can see it. It will happen in my career.
Yay. Okay. Anyone else?
So I want to distinguish a couple things. I think in sort of the regular Medicare delivery, and to the earlier comment, health plans and providers are not only working together more closely, more collaboratively, but we're kind of becoming each other in many ways. And I think part of what that means is managing the total cost of care where everybody has aligned incentives means how do we do a better job with that kind of stickiness with social determinants, with community health workers, with engagement of members with social work. So I think that's happening. I think with respect to the special supplemental benefits we've been talking about this morning, there is a challenge with a lot of community-based organizations that have been typically grant-funded around how to tie it back to an individual member getting an individual service that's in an individual plan of care in a targeted way. We've seen this in the Medicaid world historically around community mental health agencies, around addiction treatment. It's grant-based programs pivoting to more of an invoice claim type model is a difficult transition, and we're at the very early stages of that with some of these new benefits.
But on the physician side, exiting that in some ways, I mean, I think, I don't want to pretend like we got this right, but I share some of the optimism that over the last several years, the agency is paying, with some audit challenges and paperwork challenges that we're working on, but is paying for some of those additional services a complex beneficiary, and only a complex beneficiary, might actually need through chronic care management codes and transitional care management codes and others in the traditional Medicare fee-for-service space. But the traditional Medicare fee-for-service space is shrinking rapidly with 10 million people in ACOs right now, with the agency projecting a really large fraction of the rest of the people in traditional Medicare programs to be into new models like direct contracting and primary care first models, in which there are significant payment reform elements, many of which directed at kind of breaking the cycle of unit-based billing that needs to be audited, and instead replacing it with capitation and risk. And so I think it's a reflection of exactly some of those same concerns. And do we have it right yet? No, but I think we're evolving as rapidly in that direction as we can.
Okay. Yes, we have a question right here, and then we'll go to Chris.
Hi, my name is Laura Cohen. I'm with Rehabilitation and Technology Consultants, and I'm a physical therapist by training, and I'm very grateful for this conversation. It's exciting to see change happen. Tim, I have I have two main questions. The first one has to do with MCO accountability, and in the news recently, they're talking about decreasing the requirements on the monitoring and reporting from the MCO standpoint, and when we're in an area where we want more data and want it more standardized so we can aggregate it, any thoughts on what that's going to look like, or where you would recommend that go? And the second thing is about thinking about outcomes. I do a lot of thinking about that. I really like the discussion about functional outcomes because the populations that we're talking about, they're complex. And the research methodologies that we have available to us for the acceptable randomized clinical trials takes away the complexity and the context. And it's not allowing us to collect the important information. And so I really like the idea of being able to look at functional eligibility requirements so we can aggregate it over larger populations and also generalize to larger populations. And then also the timeline. I think that a lot of the research outcomes we're looking at are too short to be able to see the outcome that we desire, because you're going to have a greater cost up front, but you're going to see the outcome over a longer period of time.
Okay, let's see if we can get Tim to address
I've
some
forgotten
of this.
even two of them already. I agree with that last point about time horizons, and is a constant challenge for us. And I think only exacerbated by the types of services that we're talking about here. But to your original point, I think you're referencing some agency proposals related to network adequacy primarily. And I guess I go back to flexibility with accountability. I mean, I think that as an agency, we're always trying to find the right balance between what we make health plans or providers or others report to us versus what we just monitor in terms of outcomes. And this is a proposal that is just the agency trying to find what we think is a better balance between those two things. But to I think, triangulate with your third point, our ability to measure stuff for complex populations is still challenged, and we've invested a lot in trying to come up with new, more outcome-focused measures, but that really get at things that we feel like matter more than even some of the clinically based outcome measures that we tend to focus a lot on today. And so there's progress, but I think we'll be in a progress phase for a long time before we feel like we've nailed it.
Okay, let's get the microphone to Chris.
Chris Jennings with BPC sometimes. I do, I want to also convey sort of the excitement of this discussion because I've been around for 35 more years of doing talks about this, and this feels like a real engagement of the payers and the providers seeing a similar challenge and an opportunity, which I think is, it's so rare in healthcare, we should just say, hallelujah. Having said.
Here it comes.
No. So I wanted to ask a little, we haven't talked that much about the downstream. So it's who delivers these non-medical services, who manages them, who pays for them. I feel like we haven't really engaged today. And, and how do we monitor them and all the rest. And I wonder if we could just have a little bit of a conversation about that too.
Who would like to begin?
I might just start, just kind of one thing, which is that since I work with a lot of these providers, and the thing that just keeps striking me over and over again, and I alluded to it earlier, is just, in a given market, so first of all, in traditional Medicare, you have a network adequacy, you have medical providers, they have provider numbers, it's like you need to go find physicians, you can get physicians in your network, whatever. Now we're talking about, okay, and then we do dentists and, whatever, and supplemental. We kind of know how to find them, and there's now, I think, entities that do that, although I'm still a little fuzzy on that. But so now we're talking about, CMS says you can pay for pest control. What? Literally says that. So pest control, transportation, home delivered meals, is that like Sunbasket? Is that and then the home care providers, there could be 60 different agencies in a given market, most of whom are franchise organizations. You know, and I know just from working even with skilled nursing facilities and home health agencies that have provider numbers, how incredibly hard it is for the plan and the provider entities to connect up around value-based care, because there's 100 of them in a given market. So it feels to me like we are really missing a fundamental kind of infrastructure layer that will enable the plans to interact efficiently with these groups and to feel confident that they're being managed effectively. Just to echo Chris's
Can I build on that? So I think it's I think this is a good point. I think we're almost waiting on like Thumbtack or something like that to come along to connect these services. I think one of the things that we're thinking a lot about, Chris, at the Academy is really this caregiver education mechanism at primary care. I don't think family physicians or primary care can do this all. I think there's going to have to be some or multi-party production of healthcare as people live longer, and I don't know what that looks like. I won't even suggest how you pay for it. But I think the absence of a more robust caregiving role, I don't know that you can really roll all this out. I think there's too many cracks that it falls through.
I'm glad you raised the point, Chris. The infrastructure, and I sort of alluded to it earlier, the infrastructure building is not to be underestimated. There are entities that can deliver these benefits, different for different types of benefits. We did look at pest control. We did look at kind of almost like an RFP process in a couple of places we were looking at it. So there's part of it is, like, what's the payment arrangement? Part of it is, how do we push a roster to these entities of who our eligible members are based on the plan of care targeting that we've talked about? Part of it is, how do we capture the data? How do we ensure that there's integrity at the point of delivery, that it isn't kind of just being distributed to kind of anybody in a grant-based kind of world? I think that that's a lot of the work that is happening behind the scenes. I think that's why it might look like slower adoption in 2020 than it'll look like in 2021. There are some solutions that are easier. There are like the vendors that deliver home kind of meals. You can piggyback the kind of grocery delivery mechanisms. You can use debit cards and kind of lock down certain codes and certain kind of barcodes. There are ways you can target it, but it requires the vendor contracting piece and the roster push piece to say it goes to these 8 members but not to these other members. That work is happening, I think, kind of broadly at a lot of the carriers and the health plans. But I think that has been the rate limiting factor for 2020 more than anything else, honestly, more than that. I mean, there's broad interest in this, but the rate limiting factor is the infrastructure short term.
So infrastructure questions, right, and variability. Even if we tell you can pay for a month of transitional housing for somebody, that's probably a different proposition for a wheelchair user in San Francisco than it is in Cleveland, right? Just on like pure infrastructure and housing market issues, the ability to deliver meals is really different in the Upper Peninsula of Michigan than it is in Detroit, just by virtue of like transportation infrastructure and geography. So that matters. There's infrastructure questions about the capabilities of either the plans or the ACOs or the providers or the community-based organizations with whom they might partner to deliver stuff. I have big questions about, like, is a closed network plan gonna like build capacity, right? Is that capacity gonna be part of the care team, or are they just gonna contract? Like, I think those are really interesting questions where we've seen the most like obvious development has been through the aging and disability networks and with our partners at the Administration for Community Living, and seeing what we think are really important and interesting partnerships between the medical system, for lack of a better term, and the aging and disability networks, whether it's area agencies on aging or Aging and Disability Resource Center, Center for Independent Living, or like all of the others that have been built over time. I think it's an obvious and important marriage of skill set and relationship with populations with like where the money is. Important questions for us to ask, like as a people and government, about roles and responsibilities in bigger picture ways, but that's where I think we've seen the most action so far.
And I think on the I want to kind of refer back to the fee-for-service part of the report. I think this is going to be a big challenge in terms of who owns that accountability to do this work, because with a health plan or an ACO, there's an organizing entity that can drive it. I think it's less clear who the organizing entity to drive it is in the fee-for-service space.
The organizing entity is struggling even now. So, I had literally a home care agency owner send me an email with an attachment that was the claim form that the MA plan sent her to tell her to fill out without telling her what the rate would be, whether it would be authorized. The person needs service yesterday. So, these insurance companies are really big, and you got, people interacting with providers at that level who don't know what's going on. It's a big challenge.
Okay, this will be our last question.
Hi, I'm Kathleen Shee with the ALS Association. Thank you so much for the work that you're doing. You've mentioned home care and activities of daily living a couple times. And while I highly value all the other things that you've been talking about, for someone who's seriously ill and doesn't really have a chance of recovery, the non-medical home health is really critically important. Under the current the traditional Medicare benefit right now, you can get up to a certain amount of home health hours, 35. But it's hard to get because the agencies won't provide it because of their reimbursement. So I just want to put on the table that as we look forward to sort of think about, how do we, it's really about long-term care. I mean, we all know that. So just to continue to think creatively about how we can provide someone to come in the house, to help you get dressed, to help you turn, go to the bathroom, get something to eat. I think those are really the most critical needs.
Wow. Yes. It's all about long-term care.
Yes.
That's a good point, Elaine.
But not to underestimate the comment Tim made earlier, there are a lot of people on Medicare who have, serious and persistent mental illness, who have addiction disorders that Medicare doesn't serve. So there's long-term care is absolutely critically important, but I also think about those other kind of wrap benefits that drive. A lot of people don't go in for preventive screens on medical stuff because of addiction or mental illness. So let's not forget about that piece as well.
Okay, so we've come to the end of our time. Some of what we heard today, very quickly summarized. We may not see much in the way of benefits in 2020, a little too soon, so hang tight for 2021. We heard quite a bit about challenges in infrastructure, accountability, and in building evidence. On the building evidence side, we at the BPC, we're going to continue our work in this area, and we hope to do some additional analysis over the next year that hopefully we'll be able to contribute to that a bit. Before we wrap up, I wanted to again, thank the Commonwealth Fund and Melinda, and also the SCAN Foundation. And I know Bruce addressed the group earlier, but we also wanted to mention Gretchen Alkema and Callie Peterson, who have been very supportive and committed to these issues. And also I wanted to mention on our own staff, Dina McDonough and Natalie Weiner, who contributed heavily to this report and the process. Thank you very much for being here, and stay tuned for more. We plan to keep working on this.
Yeah, it's good to see you.